Hey guys, Dr. Lee Welch of the Running PTs here. Today I'm going to talk to you about common running injuries. So, uh, common running injuries, it's important to understand, what the common running injuries are, so you can identify, what's hurting, what's normal, what's abnormal, and potentially educate on some of the ways that you can not only prevent these from happening, but once you identify one, to do a little bit of self-treatment prior to coming into PT. So the most common research would show the most common running injury is patellofemoral pain syndrome, also known as runner's knee, which is pain around the kneecap. We usually see this after running. A lot of times this doesn't hurt that much during. If it hurts a lot during, it's just a more advanced case. There are many causes to this. Your anatomy, this is more common in women than men. Your anatomy, hips being wider than the knees, can create poor tracking of the kneecap. Increased pressure behind the kneecap causes pain around the kneecap. Muscle imbalances can cause this. Females tend to be a little bit quad dominant, meaning their quads are significantly stronger than their hamstrings. And quad dominance can lead to movement patterns to take advantage of the strong quads, and that can lead to overutilization of the knee. Hips and core, not utilizing the hips and core as much as you can, which is basically like a postural impairment with running. That can create a postural impairment with running, I should say, and strengthening the hips and core can help with this. And then just running mechanics in general, we see a lot of run form problems that can cause this: hip collapse, pelvic collapse, overstriding, a weaving gait pattern with one leg kind of crossing over the other underneath you, a crouched or sitting back gait, and a low cadence being how many steps you take in a minute. So the general treatment is to really understand why it's hurting. That's the quickest and most effective way to fix the injury. Addressing symptoms, treating symptoms with modalities in this case doesn't typically work that well. Manual therapy, some of the scraping, dry needling, the results are relatively underwhelming for this sort of pathology. So in this case, it's really important that you address the driver behind the injury. We like to look for running mechanics, and then the research would show that strengthening your hips is the gold standard for this, along with strengthening the quads if that's an issue, but strengthening the hips, the glute med, glute max, some basic isolated hip strengthening exercises can be effective. You can find a lot of hip strengthening exercises for this pathology on our YouTube channel. But we also see tape can help temporarily, like if somebody's got a race and we don't have time to really knock this out, sometimes taping can significantly resolve the symptoms in the short term. It's not meant to fix the problem. And then sometimes with men, stretching or mobility can be an issue that can lead to this, but you'll more commonly see this in women. IT band syndrome, most common running injury in men. That's pain in the knee, but it's on the outside of the knee. So you can see this red hot spot is meant to identify the site of IT band pain. The IT band is a long, thick band of fascia that runs down the side of your leg. It is not contractile tissue. It does not lengthen. So I like to say that when somebody has IT band pain, it's never the IT band's fault. The IT band is typically not congenitally short. It's very rare. So typically what's happening is there's a movement pattern that is creating excessive lengthening of the IT band, and it doesn't lengthen, so it rubs on the outside of the knee. An example would be like a crossover gait pattern. Crossover gait pattern being one foot, like if there's a midline, like if you're running down the road and there's a line in the middle of the road, one foot, and then the other foot weaving over that center line, that would be like a crossover gait pattern. That would put tension on the IT band because it's on the outside of your leg. That can increase the pressure on the outside of the knee. It's not always what causes this, but that's one example. This, if you've never had this is one of those injuries that you want to respect. It's not sinister. It doesn't scare me, but it can shut you down the pain can become so intense that you actually have to stop running. The classic presentation of this that we see in the clinic is 4 to 6 weeks before a marathon. Somebody goes on their long run, and 8 miles into a 18-mile run, they start to develop lateral knee pain, and it's the last big workout, so they push through it for 5, 6, 7 miles, and they're hobbling, and then they finish the workout. The best thing to do if that happens is to stop and figure out why it's happening, because it's usually a very quick fix. This is usually easy to fix in the clinic. When I see patients that have done this, I typically recommend a complete shutdown from running, because it's a lost cause. If you try to go back out there after having to stop and walk because of lateral knee pain, it's going to hurt if you try to run again within the next 4 or 5 days, certainly you're still going to have pain. It's just going to make it worse. So I typically require or recommend a week off after this injury and come and seek treatment. This is one of those things that dry needling can be really effective at managing the symptoms of pain on the outside of the knee, but we still want to address the driver being what caused this to happen in the first place. So that could be poor form, asymmetry at the hips or the feet, poor hamstring flexibility sometimes, hips not being very strong, soft or cambered surface running can cause this. We see this sometimes after somebody has been running with somebody slow at a slower pace than they're used to, or excessive downhill running. Old shoes can sometimes be a tell. Sometimes patients will report IT band when their shoes are starting to wear out. Their IT band starts to hurt a little bit. And pronation is a big driver behind this. And pronation is an issue that needs to be addressed either through reeducation, movement pattern correction, or an orthotic or a temporary post or a wedge or something like that. And we can help with that. So this is one of those injuries that you got to find the driver. You can't just treat the symptoms. Treating the symptoms does help, but it won't go away typically unless you fix a problem. General treatment of IT band syndrome: stretching, mobility work, strengthening the hips. Research supports strengthening the hips and addressing run form. We find that clinically that's one of the quickest ways to resolve this, along with some dry needling. And if it happens 8 miles into a long run, my best advice would be to stop and walk it out a little bit. Think about your form, initiate running again. And if it continues to hurt, it'd be best to just bail on the run. You don't want to run through this for more than a few miles, because it can get bad really quick. So sometimes compression helps. Faster running slow, running downhill can make this worse. Dry needling helps in the short term, and then shoe modification, shoe change, inserts, that sort of thing. Plantar fasciitis, nasty injury. The hallmark sign of plantar fasciitis is pain at the heel, especially first thing in the morning. A lot of patients will report pain in the arch. That's not always plantar fasciitis. Plantar fasciitis is typically back on the heel where the plantar fascia originates. That's kind of the vulnerable watershed area. The typical prognosis for this, the research would show, is 10 months without treatment. It's not something that you can run through. It's something that you can run through, and that's, I think, why we see it last so long. It's not something you necessarily should run through. Sometimes if you rest early, you can prevent a long-standing problem. The reason this can be so long-standing is because the plantar fascia will develop a significant adhesion or scar tissue, if you will, at the origin. And your body's got to get rid of that, go through the normal phases of healing. And the worse that is, the longer it's going to take. So our manual therapy techniques can help to break that up. Sometimes we can get patients feeling better in 4 to 6 weeks that have a bad case of this. And sometimes it's a lost cause. It just needs to go through a normal course of healing, which can take months at times. But typically, if patients seek treatment early enough with this injury, or they rest when their body's trying to tell them to stop, they can prevent this from becoming a nasty injury. General treatment, research would support orthotics. I will say not all orthotics are the same. The typical orthotic you'll buy over the counter works for about 75% of foot types. But if somebody's got an abnormal foot type, I shouldn't say abnormal. If somebody has a foot type that is not the normal foot type, which is called a compensated rear foot varus, a typical over-the-counter orthotic will not work for treating this injury. You've got to be in the right kind of orthotic, and that's what healthcare professionals are for, is to put the right orthotic on the right foot. Taping temporarily can help. Dry needling and manual therapy sometimes can be quite effective. Research supports manual therapy for the first 4 weeks of onset, meaning that it can be very effective at managing and reducing the symptoms for the first 4 weeks. Stretching the big toe, the calf, and strengthening the foot muscles can help as well. Another injury we see frequently is called Achilles tendinopathy. This can be mid-substance or insertional. Mid-substance meaning it happens in the middle of the tendon, and insertional is back on the back of the heel. Mid-substance is easy to treat. Insertional Achilles is not easy to treat, meaning some patients just don't respond to it. You have to really respect an Achilles injury. That's why they refer to it as your Achilles heel. Particularly respect an Achilles injury when it's on the back of the heel on the bone. Those are the types of injuries that can become a big problem, and you can lose running forever if you let that get out of hand. You can create a big calcification of the bone into the tendon. The tendon can start to develop calcium deposits, which turn into bone. And you can imagine bone in a tendon doesn't feel good, and you can't really get rid of it, depending on how advanced it is. We typically don't see it get to that point, but you do want to respect an insertional Achilles. Mid-substance Achilles, really common, doesn't scare me as much. You do still want to respect it. Overtraining, speed work in particular, this Achilles is really sensitive to speed work. That can really cause this to become a problem. It can oftentimes be a form-related issue, not using the glutes enough, using the calves too much, changing to a forefoot or midfoot strike too quickly can cause this to happen, and having tight calves or mobility of the ankle can be sometimes correlated. General treatment, the gold standard research would support eccentric strengthening, which is the lowering phase of a calf raise. There's good evidence also for what are called isometrics, which are just holding a calf raise for an extended period of time. These help more in chronic cases than acute cases of Achilles injuries. We really just want the individual to rest until it feels better, and typically that's all it takes. Calf and ankle stretching only if there's an inflexibility issue. We don't want to stretch an acute tendon injury or acute muscle injury that can actually make it take longer to heal. Sometimes we see a correlation with poor hip flexor flexibility. Dry needling, interestingly, can help with this. And sometimes what we refer to as scraping or instrument-assisted soft tissue mobilization can help if there's scar tissue that's adhered to the surrounding structures. Posterior tib tendinopathy is pain along the inside of the ankle, right behind the ankle bone, typically. Sometimes it can run up into the backside of the shin. This is a pretty common injury, typically due to overpronation or being bow-legged, which can cause more pronation. Poor flexibility of the big toe or poor hip flexor flexibility can be a risk factor. And also, interestingly, increased or excessive flexibility can cause this. We see this really often in runners, the early stages of a running career, so to speak. When somebody picks it up, this is an injury that sometimes people will pick up if they haven't really worked on form, they're not in the right shoes, so that sort of thing. Typically pretty easy to treat this. You want to address the contributing impairments, whatever those are, accommodate for those. Running mechanics, having a nice compact form, avoiding overstriding. Orthotics and taping can help, particularly orthotics can help to fix the issue. Taping can help to manage it while you're fixing the problem. Dry needling is very effective with this injury, particularly if it's up behind the shin. And eccentric strengthening helps as well to help to remodel the tendon, that is, return it to its original state. Hip strengthening is also supported in the research. We see really frequently, we see strains, muscle strains in the hip, the outside of the hip, the back of the hip, or the hamstring. These are the sorts of injuries that patients often let linger for months or years. They're typically not an inflexibility issue. We see these very commonly in flexible females. They're almost always related to run form, overtraining, or not taking time off when they should be, or another type of overtraining would be just having all intensity days. An example would be half marathon training and HIIT type workouts on your off days. So intensity, that can lead to these types of injuries, not having any downtime from a intensity standpoint. Really common after childbirth. If there's any sort of pelvic floor dysfunction, it's very common that that does happen. I think that it gets kind of brushed under the table a little bit too much. These things shouldn't be, they should be expected and acknowledged, and you could seek treatment if there are symptoms due to pelvic floor dysfunction. There are practitioners that can really help with that. General treatment for the hip in particular, foam rolling helps to loosen up the muscle and fascia and helps with pain. Strengthening the glutes and the muscle that's involved are very effective treatment with this. Addressing any other contributing impairments, core strength, poor flexibility of an underlying muscle group or joint, and dry needling is really effective with muscle. So any muscle, dry needling is going to be typically part of the treatment plan. Understand dry needling as a tool. It's not the fix, but it's a powerful tool in a practitioner's hands to help symptoms feel better. So we really want to fix the driver here. Oftentimes, this is a run form issue coupled with excessive flexibility, too much stretching, not enough time on the foam roller. So femoroacetabular impingement or pain in the front of the hip. This is a really common injury that we see in women. Risk factors can be increased flexibility, a lot of plyometric style workouts with a lot of up down burpees, jumping, glute weakness, and then anterior pelvic tilt can increase the incidence of this. Research supports strengthening. In my experience, these either get better or they don't. And when they don't, we typically try to really address the underlying driver behind it if we can, from a overuse standpoint, because this is not something that you want to. This is the type of injury that leads to labral tears in the hip. The labrum is like the hip joint is a ball and socket. So the socket is ball socket. The socket has a labrum that runs around the perimeter of it. It's like almost like, think about a suction cup that kind of deepens the socket. Labral tears is probably the most common surgery we see here at the running PTs postoperatively. Labral tears are not something that you want to have repaired if it's not necessary. And I think that a lot of those can be avoided if this sort of injury is not getting better with treatment. Typically, they just need more time than most of us want it to take, including myself. These injuries sometimes can take 6 months to a year to really resolve. Typically, that's not the case. But change in run form can sometimes be very effective. Activity modification, like not doing as much up downs, not doing as much deep squats. Try not to sit in deep chairs. Posture re-education, and sometimes dry needling can help with this if the muscle is involved in the front of the hip. So that's all I have for you guys today. If you have any questions, feel free to email me at lee@therunningpts.com or come and see us. And we'd love the opportunity to help you with anything that you're dealing with. Thanks.